The topic we have basic functional neurosurgery, and this topic is. Let's have a next slide, Asad. Yes, these are the topics which Asad has given me, which are more like like mix of neurosurgery and neurology. So I'll try to cover the major portion of it, and most likely to know the functionality of thalamus, basal ganglia, and this PET scan and functional MRI. So let's have another slide. So brain alone is a source of our pleasure, joy, laughter, amusement, as well as our sorrows, griefs, and tears. And this was said about years ago, and now we know that it's very right. So I said, maybe move to next slide, please. Sir, can we move to next slide? So usually the human brain is same as the other mammals like
Dr. Aurangzeb, you are mute, so kindly unmute yourself.
Hello.
Ji, mute. You are mute.
Can you hear me now?
Yes, we can hear you.
Compared to the other mammals, humans have a well-developed precortex, as well as in comparison, there are certain things which are decreased inside and certain things which are increased inside. Overall, the frontal area of the brain and the decision making of human is seen to be more advanced as compared to the other mammals. So, can we move to the next slide, Asad?
Yes, sir. Sir, someone is along with you and hearing with you, so the voice is getting double. So ask him to mute himself.
Is it fine now? So these are the layers of the brain. We can see that there are brain is a multi-layered, but what we will talk about today is that grayish area that we can see to the inner brain, more on the inner brain, and the function of the cortex. Asad, can we move to the next slide now? So cerebral cortex is more like having sulci, gyri, as well as central sulcus, which divides frontal lobe and the parietal lobe. There is a longitudinal fissure that divides the two cerebral hemispheres, that is in the midline, and there is a transverse fissure that divides cerebrum from the cerebellum. So there are Sylvian fissures that divide the temporal lobe from the frontal as well as from the parietal, that is a lateral fissure. Asad, to the next. So as I said in the very first slide, that precortex frontal area of the human brain is more developed as compared to the other mammals, and it has more significant function. That is, the frontal area is the major area that differentiate us from the other mammals that we will know in the coming slides. Asad, can we have next? Frontal lobe of the brain is very important in regard that it not only have format of controlling the memory, emotions, decision making, and the personality. When to get emotional, when to take certain decision, when to react to something is more connected to the frontal cortex, and this is very important. Although these decisions are taken from here, and they are then lapse towards the thalamus and basal ganglia, but this is the area which takes decisions. So this is very important to know. Asad, can we move to the next one? So Broca's area, very famous area for the brain, that is more relevant to the left area. Its ability to it has a motor function. जब भी हम कोई बात करेंगे, किसी ने हमें कुछ कहा, जब भी हम उसको लिसन करेंगे और उसके बाद हम कुछ कहना चाहते हैं, that is a Broca's. बट अगर हम वो बात उसको उस तरह से ना बोल पाए तो इसका मतलब ये है कि ब्रोकाज एफेजिया हो गई है। तो बहरहाल फ्रंटल, whenever the frontal area is not working well, so there is a diminished rage, decreased aggression, poor response to the emotions, as well as epilepsy is more related to the frontal as well as the parietal temporal area. So patient can have a uncontrolled repetitive action gestures that is more related to the frontal area. Asad, next please. So we have this premotor area, preorbital area. These take more like decision making is carried out in the preorbital areas, as well as there is a somatosensory cortex, uh, which takes this sensation, temperature, and general awareness of the body that is taken from this area. Premotor area not only plans but execution of the plan is taken from the premotor area. Asad, next please. Parietal lobe, we all know that it is have the sensation, primary sensory area, whatever we have to proprioception of the body, awareness, whatever the object we have in the hand is more if we are aware of that object is more related to the parietal area, the calculation and everything, or the shape, size of something. If we close our eyes, can be judged by the parietal area. Asad, next. These all eventually will come to the thalamus and basal ganglia. So we just have to go through this superficially. Again, gustatory center that is more like connected with the taste. This is the parietal lobe, which we can see there is a central sulcus which divides the parietal and the frontal area. That again, somatosensory area, which can be seen is more relevant to the sense of pain, temperature, proprioception of the human being. As the next, please. So, occipital lobe. Now, occipital lobe is more connected to the vision. It is even difficult to calculate during the examination if there is a meningioma or tumor in the occipital lobe because only the vision is affected, and sometimes patients are unaware of that. So, primary function is vision, but next slide, please. But there is a visual association area that interprets the information of the visual cortex or the vision. That depends that आपने किसको देखा है। अगर आपका कोई जानने वाला है, अगर समवन जिसको आपका कलीग है या कोई आपका दुश्मन है, आपने उसको किस तरह का रिएक्शन देना है, दैट इज अ विजुअल एसोसिएशन एरिया। अगर आपने किसी अननोन पर्सन को देखा है, आप कभी भी रिस्पॉन्ड नहीं करेंगे उसको, आप देखेंगे एंड यू विल नॉट रिस्पॉन्ड टू इट। बट अगर आपको आपका सुपरवाइजर या आपको नजर आ जाए अपना हेड ऑफ डिपार्टमेंट, तो डेफिनेटली आपके रिएक्शंस में मुख्तलिफ होंगे। लेकिन अगर आपके विजन में ऐसा बंदा हो जाए आ जाए जिसको आपने पहले देखा है या उससे आपका झगड़ा हुआ है, राइट, तो उसके लिए जो विजुअल विजन से आपने तो उसको सिर्फ देखा, तो वो चलो एक इमेज बनाया कि सामने कोई बंदा है, लेकिन उसके बारे में जो भी आपकी मेमोरीज हैं, जो भी आपको उसको कैसे रिस्पॉन्ड करना है, दैट इंटरप्रिटेशन टेक्स प्लेस इन विजुअल एसोसिएशन एरिया। नेक्स्ट सर। So again, visual association area and occipital lobe, which is connected with the vision, almost they are together and they are in the particular occipital area. And this is very important to know that these decisions are taken by visual association area. Again, it will come to the thalamus, which we will talk next. Next, sir. So, temporal area, it has one is aphasia, which takes place in the more dominant, that is left hemisphere. Now, what happened that if someone speaks, अगर कोई बात करे और हमें उसकी बात समझ में आए, तो हम उसको रिस्पॉन्ड करते हैं, लेकिन अगर उसकी बात ही हमें समझ में ना आए, दैट इज वर्निकीज एफेजिया। वो कहता है कि आपने खाना खाया, पर्सन इज नॉट एबल टू अंडरस्टैंड, वो बोलेगा मौसम बहुत अच्छा है, रिप्लाई में उसको समझ में ही नहीं आ रही कि सामने वाला वो इंटरप्रिटेट ही नहीं कर पा रहा, दैट इज वर्निकीज। सो दैट इज इन द टेम्पोरल एरिया। So this is the importance of a temporal lobe, and again it is related to the memory, to the hearing is ये ज़्यादा इम्पोर्टेंट है कि वॉइस वगैरह की जो मेमोरी होती है, ये वॉइस जो है रिलेटेड है मेरे किसी मेरे फैमिली रिलेटिव को, मेरी मदर को, फादर को, ये मेरे भाई की आवाज़ है। सो वो जो मेमोरी होती है वॉइस की, दैट इज मोर रेलिवेंट टू द टेम्पोरल लोब। नेक्स्ट, so arcuate fasciculus, these connect the both uh, uh, this Wernicke's and Broca's area, and if it is affected, definitely a person will not be able to understand, not will be able to respond to any conversation he's having, and this is a very rare disorder, so that comes under conduction aphasia. Next, Asad. So this is all functionality of the brain, and that is the cortex, and definitely cortex is connected to the deep structures. Next, Asad. So this is the presentation of the areas we just discussed, and we can see and we can monitor these areas. This presentation can be available, and we can just see that where these areas are present. Nowadays, if you will go to the talks or any examination, so these areas are usually asked. There is a map of the brain, so you can see through these things, which are also available on the net, and you can respond accordingly. Next. So now we'll come to the more important area, that is thalamus, basal ganglia, and other systems of the brain. Next, Asad. So thalamus is located between the deep in the cerebral cortex, and it is mostly related to the sensory system, and not only the sensory system but also to the decision making and to the other movements of the body. Next. So it is usually the inner chamber. In the Greek, thalamus means the inner chamber. It's a oval shape. It can be divided into the epithalamus, thalamus, hypothalamus, and subthalamus. But we are more, we'll keep our talk up to the thalamus, just to the functionality and a bit of anatomy of it. Next, Asad, please. Can we have? Next. So here we have a thalamus that is deep, and usually it is very difficult that we can either reach by endoscope or microscope to such a deep area. We usually need a very uh, probe-like, very minute, minimalist probes to be there, and that can be done by either we are doing biopsy or we are doing this DBS or thermotomy. That is all we can do. Above that, or if there is a bleed, some people try to take out the bleed, but definitely that doesn't work in the patient health. But this is a very deep structure. Next. So, neuroanatomically, it can be divided into this medial group of nuclei, lateral group of the nuclei, and anterior group of the nuclei. These nuclei control all the movements of the human body, and uh, there are usually they have a different functions. We are not going to discuss that. It will become very lengthy, and we will just name them because अक्सर ये भी एक difficult चीज बन जाती है. So we'll just superficially name them so it can be easier for us. So next, so when we have three groups, this is ventral, dorsal, and lateral. So it is divided like ventral, anterior, ventral, posterior, and this is medial and lateral. Simple. So ventral, medial, and ventral lateral are also called. Then we have dorsal or lateral, that is lateral posterior, lateral dorsal, or pulvinar. So we have to keep them very simple. Next. So if this is a medial, so it is midline, dorsomedial, centromedian. So these are the simple names that we have to give, and but they have got their different functions, but we have to name them very simply as they are. So they are subdivided into the other nucleus and relay stations, but we don't have to go to it. So if you have anterior, medial, lateral, and everything, if you have medial, so dorsolateral, then we have a dorsolateral and dorsomedial, and now you have a medial group, so it's a centromedial, dorsomedial. So this is simply divided into this. Next. So this is the thalamus, and this is the medial part, and there are certain nucleus which can be seen uh, in the nucleus, and this is the area that we have to work on if we are doing deep brain stimulation, thermotomy, or if we are getting some biopsy from this area. Next. So function of the thalamus, it serves as a great sensory relay station. It's the all the sensation, that is 98% comes to the thalamus, and decisions are taken from here. It is also maintains the reticular system, that is awake system of the consciousness of the human being. It's also responsible for subcortical perception of sensation and concerns to the muscular movement, muscular movements, connection to the basal ganglia, cerebellum, and motor cortex. And again, integral center for the sleep electrical activation. Next. So if something happens to the thalamus, there are certain uh, syndromes that can occur, that like a thalamic syndrome can occur because of the infarction, can occur because of some mass, can occur because of the bleed. It depends what pathology is there. So supposedly, if there is infarction that may be due to the thalamo-geniculate or posterolateral artery, uh, it can have certain clinical impact. That is, of course, to the contralateral side. That is, there can be a motor response. There can be a paresthesia. There can be a pain. So there can be a homonymous hemianopia. That is that patient will have loss of uh, particular eye in both sides. Like if the nasal side is gone in this way, in on this side as well as on the opposite side. So that is homonymous hemianopia. Tremors is the only thing which we can differentiate thalamus from the cortex. Baki, all other signs and symptoms are almost same. So it will affect the contralateral side, and patient can have this homonymous hemianopia, tremors, and movement disorders on the contralateral side. Next. So again, another sign which can differentiate is the thalamic hand. It is, uh, of course, on the contralateral side is the flex pronated with the wrist and metacarpopharyngeal joint and extended at the interpharyngeal joints, and which can have a presentation like, next slide, please, like this. So this is called a thalamic hand, and it can happen after any infarction, any tumor, or any other pathology to the uh, thalamus. Next. These are different presentations of the thalamic hand, which can be discussed. But again, it is not only the thing that we have to go into. These are the different presentations. Alien hand syndrome. It's again a sensory relay station, and as well as the motor fibers pass through it. So sometimes patient have this alien hand that which has uncontrolled movements and failure to recognize the ownership of the limb. This can also happen. Again, it's a rare thing, and rarely it happens, but it can. And again, it is related to the thalamus. Next. Second is the pain. Pain because of the thalamus. These are some procedures that are done in foreign countries, that patient has a severe pain, especially due to the terminal cancer, or he has taken all the medications and everything. So then interlaminar nucleus can be cauterized to have a pain relief, because there will be no sensory input of the pain. So this is also one of the procedures in which can be done as the thalamus. Next, please. So, just for postgraduates, it has a GABA as an inhibitory neurotransmitter, and glutamate and aspartate as an excitatory neurotransmitter that can work here. Next, it has, in the summary, because there is a lot of repetition also. There is a it has all the sensory pathways. It helps in the wakefulness, consciousness. It is connected to the hypothalamus and connected to the memory. It also determines the mood of the patient. uh, that's also the genetically, that how it develops and how it a patient has its mood, so it also determines that. And these are the different presentations. We have also already discussed them all, that how it works. There is only one thing that thalamic syndrome, or if the lesion is in the thalamus, can differentiate from the cortex. That is the movement disorder, while all other things are almost same. Next. So it also causes these aphasic syndromes. That is, that can be, especially if the dominant side of the thalamic lesion is there. It can also affect the language of the person, which we have discussed in the previously. Next. So there are certain clinical importance of the thalamus and basal ganglia, that they can be their nucleus can have this excitatory, or they can be diminished by the thalamotomy for the diseases like Parkinson, essential tumor, dystonia, pain, and epilepsy. The nucleus which are most commonly used are ventrolateral nucleus, VIM, ventris intermediate nucleus, and ventrilis oralis posterior, VOP nucleus. These are the nucleus which are used by for the DBS, if we are going through this procedure, which can be done for the above mentioned diseases. Next. So now we come to the basal ganglia. Basal ganglia is a large mass again situated between the cerebral hemisphere. It has uh, many famous nuclei, such as caudate, lentiform, and lentiform is formed by the vitamin and globus pallidus. Next. So again, it's overall the collection of the nucleus, and it also represents the movement disorder such as chorea, dyskinesia, athetosis, and tremors. Next. So next it is this anatomy. Next. Next. So we'll just Asad, next slide we have this. Yes, the role of the there are different nucleus which are in the basal ganglia. They have a different role. Like a caudate, it helps in the planning the movement, learning, memory, rewards, motivation, emotions, and again the romantic exchange, which is also the function of limbic system. So if anything happens at the this level of the nucleus, that is caudate, the following things then happen: obsessive compulsive disorder. If such patient come, then we have to treat the caudate nucleus. Attention deficit hyperactivity disorder, most common disorder. This is the most common disorder nowadays. So if the medication doesn't work, DBS can be done. Schizophrenia, if the patient has a behavioral severe behavioral disorder in schizophrenia, again DBS can be done. I don't know the role of in Huntington's disease, if there is any. Again, Parkinson is a famous disease for DBS and thalamotomy, especially this movement disorder. Autism, behavior disorders related to the autism can also be treated. And Tourette syndrome, it is a movement. These are certain tics which take place during the by the vocal cords, and these can also be treated lately. So again, lentiform nucleus, it's medial to the internal capsule, and it has a certain function. Next slide, is it? Next. So next, can you go a bit up? We can just discuss the yes. So it is also helps in the learning, motor control, speech, articulation, language function, rewards, and because it is near to the quadrate, so almost all the functions are same, and it helps in the studying properly. So ataxia can happen. Patient have a dysarthria because it helps in the language, and abnormal movement of the uncontrolled violent movements like hemiplasm can happen, and it is also as a part in Parkinson disease. Next. Next, this is a very important nucleus, and the globus pallidus, and it has two forms like globus pallidus internus and externus. Usually, people think that it is only got an internus part. No, there is an external globus pallidus externus, and it is also related to the movement. So dysfunction can be seen due to the ischemia, tumor, or if there is a lack of dopamine, and it can lead to the cognitive dysfunctions. Next. Next, this is the anatomy, and because of the time duration, we cannot just go into such a detailed anatomy of these. Next, Asad, we'll just discuss the functions of the basal ganglia. So it helps to control the muscle tone. We will go next to see. It also helps. Asad, can we discuss the slide? So voluntary movements and consciousness, subconscious movements that can be controlled. So this is more. Basal ganglia is more related to the movements and movement disorder that we will know in the coming slides. Next, Asad. So this is a this whole deep system is connected together. So cingulate, temporal, orbitofrontal, because the order comes from the orbitofrontal area, hippocampus and amygdala. They are the main limbic input system, and they control the expression and emotions, that when to smile, what gesture can be given to someone. As I explained earlier, that premotor cortex and these deep structure decides how to respond, and this is an area from where everything passes, and limbic loop decides when to how to react, and to whom to react, and when not to react, and what expression can be given to a friend, to an enemy, to your supervisor. So it depends on the limbic, all on the limbic system. Next, and again, this is a goes on and on. Again, next slide, Asad. Next, this is a oculomotor loop. Again, it gets slowed down in the Parkinson disease and other diseases that are related to the deep structures like basal ganglia and thalamus, because of lack of dopamine and neurotransmitters. The decision making is taken, but because of the sensory relay station and everything, it uh, reaches late. Because of that, the movement of eye is slowed down as compared the normal human being sees. So this is called oculomotor hypokinesia. Next. So there are two circuits, especially in the basal ganglia, that works, because if we flex our hand, if we got flexion of our hand, so there are two systems working in it. It is a direct pathway and it is an indirect pathway, and both are activated simultaneously. So whenever a cortex gives order for the direct pathway that we have to carry on, what happens that it goes through the stratum and goes through the globus pallidus internus and substantia nigra. Mind it that cortex orders stratium and it goes through the substantia nigra, uh, substantia nigra and globus pallidus internus, which gives inhibitory response to the thalamus, and thalamus gives response to the cortex. So this is a direct pathway because of which the flexion and the movements occur. Now, what happens in the indirect? Cortex gives orders to the stratum, and it goes to the globus pallidus externus as well as subthalamic nucleus. Now the nucleus is changed. It is globus pallidus externus and subthalamic nucleus, which gives information to the thalamus and inhibitory information, and thalamus is information to the excitatory information to the cortex. So in this way, when we flex the hand, the certain group of muscle are flexed and certain muscle of group are extended at the elbow. So this is because of the direct and indirect pathway. Now, whenever something happens in the basal ganglia, so both of these pathways will be affected. This is because there is a rigidity in the hand. This is because the tone is changed because of this direct and indirect pathway. Direct pathway, orders are taken from the cortex, prefrontal cortex decides, it gives orders to the stratum, through dopamine. Dopamine is the main hormone of the system. So it gives orders to it. The direct pathway is taken by the globus pallidus internus and substantia nigra, and they give order to the thalamus and again to the cortex. This is a direct pathway. In the indirect, only globus pallidus internus and subthalamic nucleus are changed in this pathway. So one leads to the flexion, other leads to the extension. Anything which disturbs this circuit will lead to the rigidity, will reach to the will change to the tone of the hand. Next. So these are the pathways which was just explained. Next. Next. This is the indirect pathway, and globus pallidus externus is used in this. So next. And this leads to the hypertonicity. And what is the hypertonicity? It's the abnormal increase in the muscle tone in response to the passive stretch, which indirect pathway of the basal ganglia when is stimulated. So again, it is the same pathway which I just explained. Next. Now talking about the Parkinson, it is a chronic disease. Now which has a progressive neurodegenerative disorder. Now, the word which we can note here is a progressive neurodegenerative disorder. Whatever treatment you give, whatever you do, this will progress with time. In 10 years, in coming 5 years, disease is going to progress. Either patient is on medication, either patient is on the deep brain stimulation, or the thalamotomy is done, whatever. Disease is a progressive. So it is a characteristic slowness in the initiating the movement and execution, and increase in the muscle tone, and tremors are there, and there's a gait change. This all is because of this uh, defect in the substantia nigra and the lack of dopaminergic response. Next. So it has a hypokinesia or a bradykinesia, part of more related to the less excitation in the direct pathway of the system. Next. Rigidity, it can also occur in this, which is also the integral part of this. So it has a stiff or inflexible muscles. It can stop muscles from stretching and relaxing, which can lead to the pain, muscle cramps, and problems with the balance. Now rigidity is a main reason, because this balance and everything related to it. And next. Now, this rigidity not only affects the limbs, but it can also affect the breathing, speaking. So, breathing and speaking, chewing, all are related to the rigidity caused by this basal ganglia direct and indirect pathway. And this is a less discussed matter that we do not discuss very frequently about the breathing problem or the chewing. We say that patient has slowness, but no, it has more related to the rigidity of the muscles of whole of the body, which can even affect the breathing of such patient, and the tone. And the tone is also affected. Next. So tremors, again, the very integral part of the thalamic Parkinson's disease. It is the involuntary rhythmic movements of the distal part of the limb, and patient can have a resting tremors, absent at the sleep, increased by the stress and excitement, and it is about 4 to 6 time per second. This is also the same statement comes also in the part two paper or MCQs. It's the same statement that comes. Next. So how Parkinson disease is managed? It is managed by the medication, surgery, and deep brain stimulation. So what medications can be given? That is, levodopa is the most common, and other carbidopa and other medications that are commonly used, depending upon the affordable. They are expensive disease medication, and depending upon the patient's requirement, the dose can be increased or decreased. Anti-allergic and all this can be given. While in surgery, next, we have different options. That is thalamotomy, pallidotomy, subthalamotomy, And deep brain stimulation, that can be VIM is the most common nucleus. GPI, subthalamic nucleus, is a very small nucleus. It is very difficult to reach there, and again, it is more difficult. In deep brain stimulation, one can do, but thalamotomy cannot be done here because it's a very small nucleus. And transplant can be done of a human fetal, and xenotransplant can be done, and it's rare. I have never heard of it or seen, but it can be done for remove these Parkinson disease. Now, thalamotomy and deep brain stimulation. Thalamotomy is or palliatotomy is something that is permanent. We permanently damage these excitatory nucleuses, so they can balance each other, right? But in deep brain stimulation, we give these stimulation which can in the next stage it can lead to the excitation on the next step of the this direct or indirect pathway. So both can be done. Next, also there is a price difference. The thalamotomy is much more cheaper, but this deep brain stimulation is around 50 lakhs in Pakistan, while the thalamotomy, the ablative procedure, can be done around 6-7 lakhs minimal. So there is a cost difference between both procedures. So deep brain stimulation there is a certain probe device that stimulator that is kept in the brain in the deep structures like nuclei of the thalamus or basal ganglia, and another lead is passed, and the major pulse generator that is kept in the pectus major muscle in the chest, and certain rhythms and electric current are set to be given at certain times to per minute to the brain. These signals usually gives the stimulation to the brain and the nucleus of the thalamus and basal ganglia, and patient usually respond to it. And if he has tremors, if he has difficulty in speaking, if he has difficulty in movement, and if patient has a abnormal movement in the hand or like these issues which are related to the basal ganglia and thalamus can be resolved. Next, even the facial movements like mm, uh, auricular abnormal movements can also be treated by it. So patient with uncontrollable tremors whom medication is not effective, that is more than 5 to 7 years he has taken medication, now he is refractory to the medication. Patient symptoms that not respond well to the medication, uh, and patient has got this uh, symptoms related to the drugs. If he has got another abnormal dysarthria and another abnormal dyskinesias which are related to the side effects of the medication, then he can have a deep brain stimulation. Then the indication of deep brain stimulations become activated. Now, psychiatric illnesses like obsessive compulsive disorders, Tourette syndrome. These are the tics. These are the abnormal voices that usually come from the vocal cord when they are abnormally contracted, and they are uncontrollable and not controlled by the human. So it is called Tourette syndrome, and it can also be done in such diseases. Next. So this I have some part of it I have explained already, that the mechanism of inhibition and activation in these centers is like that. Uh, Certain hormones give excitatory response at their nucleus, but from to the next nucleus from that there is an inhibitory hormone response. ये इस तरह से ही है कि अगर किसी को जॉब मिल जाए, वो अपने दोस्त को बता रहा है कि आई गॉट द जॉब, लेकिन जो सामने वाला बंदा है जो उसका दोस्त हो सकता है उसको वो बात पसंद ना आए, तो वो डिप्रेस हो जाएगा। लेकिन इसके लिए और इसकी फैमिली के लिए तो खुशी की बात है ना। तो एक आपने दूसरे को जब ये बात बताई तो उसके वो हो सकता है कि वो बात ज्यादा पसंद ना आए, ठीक है ना। तो इट इज जस्ट लाइक दैट, एक बंदा एक्साइटेड है उसी न्यूज के लिए, दूसरा नहीं है। तो इसमें जो इनके हार्मोन्स हैं वो भी इसी तरह ही इफेक्ट करते हैं कि जैसे इनके गाबा इज इनहिबिटरी हार्मोन, वो क्या करेगा कि फ्रॉम थैलेमस टू कॉर्टेक्स जो है वो इनहिबिशन ले जाएगा, लेकिन थैलेमस को जो है वो एक्साइटेशन मिली है फ्रॉम जीपीआई एंड दिस सबथैलेमिक न्यूक्लियस। उसके पास जो हार्मोन आ रहा है वो एक्साइटेटरी है। इसी तरह ही जो स्ट्रेटम के पास हार्मोन है दैट इज डोपामाइन, वो अगेन एक्साइटेटरी है। तो इट डिपेंड्स कि अगले वाले के पास कौन सा हार्मोन है, वो उसी को ही रिलीज करेगा। नेक्स्ट। So these are the different components related to the DBS. One is this. These are there is a lead. There is a pulse generator which we can see in the picture above. This is a pulse generator, and it is about 5 to 10 years is a guarantee of this battery. It will work, and these are the leads, and these leads will go into the muscles and subcutaneously they are passed into the scalp, and in the scalp they are connected to the leads which are in the brain. In the below we can see there these are the leads which are in the brain. Next. uh, the technique of DBS, usually the MRI is required that should be done about 1.5 MRI machine, and patient is initially framed and MRI is done, and targeted are set, and on that particular MRI the markers are made, that is XYZ, and the calculation is done for the particular nucleus that is required, right? Either we have to go medial, more on the lateral. There are this fixed calculation that we have to carry on that program, that is gamma software or related to a DBS. There is a company gives us a software. On that particular, we have to mark X, Y, and Z, which represent X represents the laterality, medial or lateral, and Y represent either it is anterior posteriorly, it is more anterior or posterior, and Z represents the depth of the lesion, how deep we have to go. And these pre-made calculations are filled, and certain calculations we get from that program for that particular patient, because whenever we have this frame of DBS, that is patient is framed with a DBS frame, then the MRI is that we get is an actual representation of the patient's brain, and we usually take that particular nuclei of the brain patient on which such calculations are done. Although we can do the manual, medial, and lateral, that depends upon the expertise of the surgeon who is performing. But we have pre-made calculations that can be used. Next. So side effects of the DBS can be difficulty in speech, which is most common, mood change, bleeding can occur if some vessel is touched, uh, patient can have a seizure, it may not function as we are intended to, patient may have a confusion, and there can be any erosion, malfunctioning, or even the leads which are placed inside can fracture. Next. So these are the certain conditions. Next, we will talk later. So now we come to the PET scan. PET scan is usually the used for any disease that can be diagnosed. Either it can be epilepsy, it can be a tumor. Uh, PET scan can be used for such diseases, and a radioactive tracer, that is glucose. Glucose is the most common tracer which is used. There is a methionine and there are other tracers which can be used, but it has got the more, it has got the less time decay. It usually can be in the body about 3 hours, 2.5 hours, something. So it is more prone to be in the body. So fluorodeoxyglucose is the most common radionucleotide that can be used. It is used as a glucose, and whatever brain tumor patient has, glucose is most commonly utilized in that particular tumor. So it is most commonly used. Next. And it is not cannot not only be used for the brain, it can be used for whole body. So fluorodeoxyglucose is an analog. It's a chemical. It can be radioactive. There is a certain atom in it, that is fluoride, that can be used for the uh, as the tracer. As a tracer, it can be used. Next, so this is the combination of the fluorodeoxyglucose, and it is absorbed in most of the body parts, especially in the tumor. Next, now there is a normal glucose. It can be utilized. It can be taken by the glutamate, and it can be utilized in the body. But fluorodeoxyglucose, as it is the synthetic, it cannot be utilized. So it is usually blocked inside, and it will decay with the time. Right? It will get decayed with the time. So that particular time can be utilized for the PET scan to happen, right? Whenever patient is injected, patient has got around 60 minutes or 40 minutes, after which he can go for PET scanning. Next. So next image, please. So it provides the quantitative uptake of the nucleotide by the some organ that can be calculated by this method. Now, what methods can be used? That is visual inspection, that we see the images, standard uptake value, right? Standardized uptake value. This is the calculation which can be done by some methods, and which value can be given. And this is very important. The physicist and whenever we get the report, we have this standardized uptake value, which we can use either it's a tumor or it's not a tumor. And definitely the glucose metabolic rate can also be calculated. Next. So this is SUV, and that is standardized uptake value. It usually it's uh, concentrated in the tumor, and it can be like tumor activity, concentration, injected dose into the body weight, and we can have SUV. The normal malignant tumor have SUV that is more than 3 point value, right? So 3.0 is a normal value. Above that, anything above that will have the tumor. If there is a tumor, it will have a value above this mentioned value. Next. So limitations of PET scan are it is not very not only the what the, we cannot always diagnose that it's a cancer, so it's not very specific for the tumor. It can show the hyperactivity of the other systems also. So it is not very very specific to the tumor for our indications. Next. This is a normal distribution of the tumor, normal distribution of the uh, PET scan and fluorodeoxy glucose, which doesn't taken up. And this is a normal image that we take. If we will have this CT scan and MRI mixed into it, then we can have the image. Next image like these. So one we can have the image, but we have to merge the CT and MRI image into it. Next. Then we get such images. Now, what has happened here that the SUV of this spine, we can see that this is a lesion is normally seen, right? But the radiation above the SUV level of lungs and other organs are low. That is why it has showing this coloration, change of the color in that particular area. But in this area, the SUV level should be high. If we are having the uh, we are judging the tumor for the spine, then we can say that this is a particular area where the tumor is, right? And it is an active tumor. Its central is active, but not to the that normal particular area, because there is a difference of SUV, the concentration that is taken by the organ. Next. And sometimes epilepsy can be can be also diagnosed on the PET. We can see that there is a certain area which is center of the epilepsy in the temporal area, and the glucose is not taken by that particular area. That is during the normal imaging. If the patient is not having fits for 1, 2, or 3 days, if you will have an image, you will get like this. But if the patient is has a just got a fits, and you will have an image, this particular area will have a hypermetabolic activity of the glucose. That particular area of the temporal, which is now not taking any contrast, will be more brighter, more activated as compared to whole of the brain, because it is hyperactivated at that particular time. So this is how the epilepsy is controlled, first, before, and then after it can be calculated. But if you compare such image to the CT scan, we will have a normal brain. We do not see any pathology in the brain, that is a decreased oxygen or decreased any, there is a mass or something. We cannot observe anything in the brain. Next. So PET scan is a radionuclide scan that produces 3D image for the functional purpose. It has a based on its blood flow, oxygen, and glucose metabolism. With radioactive tracer, there is fluorodeoxyglucose, which is normally injected in the. It's the most common because it has a decreased delay time. While there are other tracers also, and methionine is one of the famous one which can be used. Now, PET tracer emits positrons which inhalate. Now, what is inhalate procedure? It is a procedure by which the electrons react, right? There is a positive and negative electron. Positron is positively charged. In the cell, there is a negatively charged particle already present. Whenever they will react with each other, the positive particle is induced by us. The fluorodeoxyglucose that we have given, right? That is a positively charged particle. Whenever it will go into the cell, it will have a reaction with the electron, and the reaction they cause is called inhalation. So that particular inhalation will produce two gamma protons that will be emitted in the opposite direction. Whenever they will be emitted in the opposite direction, it will reach to the certain circumference of the brain or the machine. It will both of these emitted gamma will react to the given circumference at the same particular time. This is how it is calculated. So it will be called coincident of in that particular time, right? This is
Sir,
how
sir,
it
we
is
are
calculated.
getting actually short of time. So
Uh,
kindly,
so, okay. Asad, you can just go into the other slides. We can explain the functional neurosurgery, right? Go to the next slide. I'll just explain next if there is image. Okay. अब हाँ बस यहाँ पे ही रखो सर ठीक है. So this is functional neurosurgery, a functional image of the brain that is again used for the functionality of the brain, right? In this particular area, the particular area of the brain is stimulated by the image, right? Either हम पेशेंट को कोई इमेज दिखाते हैं या कोई थॉट देते हैं या उसको कहते हैं कि अपने हाथ को हिलाएं या अपनी फिंगर्स को मूव करें, तो दिमाग का कोई ना कोई हिस्सा जो है उसकी ब्लड सप्लाई बढ़ जाएगी. जब ब्लड सप्लाई बढ़ेगी तो उस वेसल का वॉल्यूम बढ़ेगा, वॉल्यूम भी बढ़ेगा, वहां की ब्लड सप्लाई भी इंक्रीज होगी, और उसको जो है फंक्शनल एमआरआई जो है अपने इमेज पे बोल्ट इमेज, BOLT बोल्ट इमेज, जिसमें उसकी ऑक्सीजन लेवल को देखा जाता है कि ब्रेन की किस रीजन की ऑक्सीजन लेवल बढ़ी. अगर आपने पेशेंट को कोई ऐसी इमेज दिखाई जो जिससे वो एक्साइटेड हो जाए, जैसे कोई बच्चा आपने कार्टून दिखाया, वो एक्साइटेड हो गया, तो दिमाग के कौन कौन से हिस्से एक्साइटेशन में जा रहे हैं, राइट? और ऐसे कोई बोरिंग एड वगैरह आपने दिखा दिया तो फिर देखा जाता है कि कौन से हिस्से एक्टिवेट हो रहे हैं. अगर आपने राइट हैंड की ईच फिंगर को देखना है तो आप उनको बोलेंगे लिटिल फिंगर को टच करें, मिडिल फिंगर को टच करें, थंब को टच करें. तो जिस तरह से वो टच करते जाएंगे, दिमाग के एक पर्टिकुलर एरिया की ब्लड सप्लाई इंक्रीज होती जाएगी और वहां की ऑक्सीजन सप्लाई बढ़ जाएगी. तो इस तरह से जो है फंक्शनल एमआरआई जो है वो कैलकुलेट किया जाता है. इसमें शो असद अगर आप नीचे के एक दो इमेज दिखाते तो बस मैं इसको कंक्लूड करूं. हाँ, इसमें शोर का इस तरह से कि जो भी हम ऑर्डर देते हैं पेशेंट कैसे परसीव करता है, इमोशंस की कोई भी पिक्चर आप दिखाते हैं या कोई बात करते हैं तो पेशेंट कैसे परसीव करता है, राइट? तो ये उसकी इमेज है। नेक्स्ट असद, अगर आप एक तो नीचे के दिखा दें, इसमें पेशेंट यूजली शोर बहुत ज्यादा होता है, थोड़ा सा असद ऊपर चले जाए, जस्ट चले इसी इमेज पे रखें। तो इस तरह से चीजें आती हैं कि जब पेशेंट स्पीच कर रहा है तो कौन सी एरिया एक्टिवेटेड है, फिंगर टैपिंग कर रहा है तो कौन सी एरिया एक्टिवेटेड है, लिसनिंग कर रहा है तो कौन सी एरिया एक्टिवेटेड है। और आप देख सकते हैं कि रीजन के आसपास के एरिया आपको कैलकुलेट हो जाते हैं, पता चल जाते हैं कि किस तरह से हम उसको कर सकते हैं। तो दिस इज फंक्शनल एमआरआई विच इज बेस्ड ऑन द यूज ऑफ द ऑक्सीजन, ठीक है ना। ऑक्सीजन की यूटिलाइजेशन के बेसिस पे जो है फंक्शनल एमआरआई किया जाता है, और उसकी एक्टिवेशन को या किसी पर्टिकुलर एरिया की यूज ऑफ ऑक्सीजन को देख के अंदाजा किया जाता है कि उस एरिया में कौन सी एक्टिविटी है, और आप कौन सी, पेशेंट लिसन कर रहा है तो कौन सा एरिया एक्टिवेट हो रहा है, पेशेंट बात कर रहा है तो कौन सा एरिया हो रहा है, और कोई इमेज देख रहा है तो कौन सा एरिया एक्टिवेट होता है। तो विजन का, लिसनिंग का, स्पीकिंग का एरिया इसमें कैलकुलेट किया जाता है। आई थिंक इतना काफी है बिकॉज ऑफ लैक ऑफ टाइम। थैंक यू। और भी इसमें डिटेल थी, लेकिन बिकॉज ऑफ आई थिंक 12 बज गए हैं।
Thank you so much, sir. Thank you so
थैंक
much.
थैंक
Inshallah, we will try to have one more session with you uh,
यू।
to cover the remaining part. So thanks for your time, and we are very much thankful. Inshallah, this recording will be available, so we will share with it as well. Thank you so much.
थैंक
Jazakallah.
यू।